Good morning and a warm welcome to UCT-Africa Virtually NT for those of us joining us from within South Africa, from within the continent and outside the continent as well. A warm welcome to you. We have a great session lined up on Paediatric OSA by one of our registrars at the University of Cape Town, Dr. Raphael Mlauzi. I'll hand it over to Dr. Mlauzi and we'll be keen to hear what he has to say today. Dr. Mlauzi, the floor is yours.
Okay, thanks very much, Tasia. Good morning, everyone. Good morning to our consultants and registrars within South Africa and across the continent. I would like to make a presentation on obstructive sleep apnea syndrome in children, what's new. I'll start sharing my screen. You see the screen?
Raphael, I can see your screen, yes.
Okay, I'm Raphael, as Tasia has already said. So I'm a registrar in the Division of Otorhinolaryngology here at the University of Cape Town in South Africa. I have no disclosures to make. The presentation is referenced and I obtained patient consent. So obstructive sleep apnea syndrome is defined as a syndrome of upper airway dysfunction during sleep, characterized by snoring and or increased respiratory effort secondary to increased upper airway resistance and pharyngeal collapsibility. It is the extreme end of the spectrum of obstructive sleep disordered breathing, which varies from primary or habitual snoring through to upper airway resistance syndrome, obstructive hypoventilation, and obstructive sleep apnea syndrome, which is the more severe type of sleep disordered breathing, which is our topic today. So obstructive sleep apnea syndrome, which I'll refer to as OSAS from now on, affects 2 to 3% of children. 2 to 6-year-olds are mostly affected, as that is the time when they get adenotonsillar hypertrophy. Habitual snoring, which is considered harmless, affects 6% of healthy children. No difference in gender. 19 to 61% of obese children and adolescents are affected. Recent studies have shown that a history of prematurity increases the prevalence of OSAS by about 9.6%. There's a 9.6% prevalence in those with a history of prematurity. And the black race is more affected than other races. A recent study showed that children are 4 to 6% more affected by OSAS compared to Asian. In terms of genetics, there's an increased risk in siblings, and there's a of children whose parents had OSAS. In terms of etiology, the etiology is considered in 3 categories. The first one is intrinsic upper airway narrowing, which includes adenotonsillar hypertrophy, micrognathia, macroglossia, mid-face hypoplasia. The second category is increased upper airway collapsibility, which is due to decreased muscle tone, cerebral palsy, and neuromuscular disorders. And then the third category is inflammatory conditions, which include allergic rhinitis and asthma. So briefly about adenotonsillar hypertrophy, we grade tonsils using the Brodsky grade from 0 to 4. There are mixed results in research about the association of adenotonsillar hypertrophy and the severity of OSAS. However, there is no doubt that OSAS children tend to have an increased size of adenoids and tonsils. Obesity, in obesity, there is upper airway and neck fatty infiltration, which results in upper airway narrowing and pharyngeal collapsibility. As I've said in the introduction, 19 to 61% of obese children and adolescents have OSAS, and it is considered an independent risk factor for metabolic syndrome. There is active research which is going on now about biomarkers for OSAS. The important thing about biomarkers is that they can act as a prognosis indicator, and they can also show response to treatment, and they could be highly sensitive and specific for OSAS-induced end organ dysfunction. And that particular biomarker, they are supposed to be implicated in disease mechanism, and changes in levels should correlate with end organ outcome. So the one that's been studied is CRP, one of those that's been studied. Levels increase with severity of OSAS. However, it's not predictive of cardiovascular disease. It is an indicator of neurocognitive impairment and indicates resistance post-adenotonsillectomy. So there are many of these biomarkers that are being investigated. They include atropine, B-type natriuretic peptide, which has been shown to correlate with endothelial dysfunction. There's lipopolysaccharide binding protein, vitamin D, which have been shown to correlate with metabolic dysfunction. And there's epinephrine, norepinephrine, GABA, and tau, predictive or cognitive deficits in OSA. There are so many more, and if you are interested, you can go to the paper that I just cited at the bottom there. So in terms of diagnosis, we look at clinical manifestations related to OSA. The symptoms are divided into two main categories. The first category being the symptoms that are directly related to upper airway obstruction, include habitual snoring, witnessed any difficulty in breathing, a mild adenoid hypertrophy, abnormal posture, and excessive sweating, which is pathetic. The second symptoms are related to OSAS morbidity. Any history of blood pressure, of enuresis, excessive daytime, inattention, hyperactivity, cognitive deficits, academic difficulties, and failure to thrive. Questionnaires have been formulated to identify children who are at risk for OSAS. However, they cannot and OSAS, and they are not targets for polysomnography. However, they do provide full information and psychological health. So there are so many of these questionnaires which will come across in literature, but the one used mostly clinically, there are four. The first one is a score, which was designed by Brulette et al. In 1980. It consists of 3 questions, which are difficulty breathing, snoring, and observed apneas. So these questions an equation, and then a determination is made as to the diagnosis and severity of OSA. The second one is the score, which was designed by Sprite and Gonzalez in 2020. The one which we use here at Red Cross. We use a model which consists of 6 questions. One is breathing disorder, which was designed by Shevin et al. In 2000. It consists of 22 questions, and the answers are either yes, no, or unsure. As the name suggests, it's got 18 questions. Sleep disordered breathing. So if you want to learn more about these questionnaires, you can go to these papers. There's more detail there. When you examine the children with suspected OSAS, we have to look for the following abnormalities. We look for nasal septum deviation, nasal turbinate hypertrophy. Also look for obesity. You look for maxillary or mid-face hypoplasia, which could be associated with craniosynostosis syndromes. You also look for mandibular hypoplasia and neuromuscular weakness. Also, you have to examine for subtle craniofacial abnormalities in non-syndromic children. Look for a retrusive chin, a steep mandibular plane, which makes the face look a bit longer, a vertical direction of craniofacial growth, and class 2 malocclusion. There are also these complicated disorders, which are syndromes like achondroplasia, Treacher-Collins syndrome, Down syndrome, which is quite common here, Pierre-Robin sequence, mucopolysaccharidosis, and Prader-Willi syndrome. So in terms of investigations, there are a number of them which can be done, starting from polysomnography, overnight oximetry, drug-induced sleep endoscopy, drug-induced sleep sign MRI, and echocardiography. Before we get into the details of the investigations, it is important to understand the concept of apnea-hypopnea index, because we cannot describe OSAS without understanding what this is. Apnea-hypopnea index is the number of mixed, obstructive, and apneas and hypopneas per hour of total sleep time. So it is determined by a figure. So if the apnea-hypopnea index is less than 1 episodes per hour, that is considered normal. If the apnea-hypopnea index but less than 5 episodes per hour, that is considered mild OSAS. If the apnea index is between 5 and 10 episodes per hour, that's considered moderate OSAS. And if it's more than 10, that is considered. So the first investigation that is considered the gold standard is the polysomnogram. This is expensive, is not widely available, and is quite labor intense. The polysomnography will give information on electroencephalogram. Some of them you can do a video recording. You can also get electrooculogram, submental and leg electromyogram, oronasal airflow, abdominal and chest wall movements, pulse oximetry, and end tidal or transcutaneous partial pressure of carbon dioxide. The indications for a polysomnography, high risk of OSAS, like in obese children or those with craniofacial abnormalities, neuromuscular disorders, Chiari malformation, Down syndrome, Prader-Willi syndrome, mucopolysaccharidosis, and uncertain diagnosis of a sleep disorder. Do this investigation if you actually have it. As I've said, it is quite expensive and it's not widely available even in tertiary institutions. However, where it is available, you can also use it post-treatment, like in children with persistent OSAS, those with moderate to severe OSAS pre-operatively, and those with high risk of OSAS, like the ones I've just mentioned before. So you can treat these, and then afterwards you can go ahead and do a polysomnogram on them. The technical definition of OSAS is a sleep disordered breathing symptoms plus an apnea-hypopnea index of more than 1 episode per hour. So this is the technical definition that is used as OSAS. There is a second one, which is quite cumbersome from the European Respiratory Society across in published studies. But this is the one which one should know, that if you've got an apnea-hypopnea index of more than 1 episode per hour, then you can safely diagnose the child with OSAS. The polysomnogram, actually this was done last week on a child with achondroplasia. So on the right side is the technical coding, and then on the left side is the sleep summary. I would like to draw attention to the apnea-hypopnea index, the one I was just talking about. Remember, we said that if it's more than 10, then we consider it as severe OSAS. Now, if it's 77, so it is a very severe OSAS. It is multiple times, more than 20 times the normal value. Also, I want to bring your attention that the apnea and hypopnea index is actually a summation of obstructive apnea, mixed apnea, and hypopnea. Overnight oximetry is the second investigation that one can do. It is considered cheaper, available, and easy to use. And that is what we use here at Red Cross. That is the actual for the equipment that we use. It's been validated against a polysomnography. So to get valid results, one is to record more than 6 hours of sleep. It records clusters of desaturation events. So that cycle there, this is an actual recording of a 4-year-old boy that we did sometime this year in February. So that cycle there represents the cluster of oxygen desaturation. So to do when you analyze the overnight oximetry graph is to make sure that it is more than 6 hours. Then if it's more than 6 hours, then you say yes, you can analyze the information would be valid. So according to the clusters of desaturation, you also look at the percentage of oxygen it is come down by. For example, if you count these clusters and you see here there are 1, 2, 3, 4, 5, 6, already there are more than 3. So it's more than 3. Desaturation, you read it off the computer there. If you look at SpO2 level there and the events, it will tell you how many of these events are there. So if there's less than 80% desaturation of oxygen, then that is considered very severe OSAS, and it's a McGill 4. If the saturation is less than 85%, then it's a severe OSAS. And then if the saturation of oxygen is less than 90%, but more than 85%, then it will be considered a moderate OSAS. And then a McGill 1 with less than 3 desaturation clusters and no drops of oxygen below 90%. If you look at this, the treatment of these children, if you look at McGill 2, 3, 4, you can safely say this child has got, I'm going to treat this child. But however, if it's a McGill 1, then it's a problem because we know that 46 McGill 1, which is considered none or mild OSAS, actually have OSAS. So if an overnight oximetry on a child in McGill 1, so you still worried that it could still be having OSAS because it has got a high positive predictive value of 97%. Like in this case, on the overnight oximetry you're saying right now, we can safely say this child does have obstructive sleep apnea syndrome. But however, it is negative predictive value of 53%. So these are the children that you don't want to dismiss and tell the mother that you don't have OSAS, that you want to assess in terms of the morbidity. What other morbidities does the child have? If the child does have some that you could be having OSAS, it's safe to go ahead and offer them treatment. However, if you're not so worried, you might as well give them medical treatment and then you ask to review them, say in about 3 months' time. So in terms of the treatment, overnight oximetry recording, it enables us to stratify the children in terms of how urgently one should do the adenotonsillectomy we offer them. For example, if it's a McGill 4, like in this case, we would aim to do 4 days, which is what we're doing. If it's a McGill 3, we say, okay, we'll aim to do it within 2 weeks. We aim to do it within 3 months. And then if it's a McGill 1, we do the protocol that I just said. This helps us, especially for pressure of a theater time, to stratify the children, in other words, to see who needs urgent attention than the rest. There is the concept of the oxygen desaturation index, or ODI, which are the events. This is considered a more than 4% decrease in the oxygen saturation per hour of total sleep, abbreviated as ODI4. So there's been an attempt to use that to classify the OSAS into mild, moderate, and severe. This is quite new. It hasn't entered the realms of clinical, because there are times, like for example, those children with a McGill 1, you would then look at the ODI4 and then whether it will help you in decision making in terms of how severe it is. For example, if it's a 2.05, is considered mild OSAS. If it's 3.5, between 2.05 and considered moderate. And if it's 4.15, is considered a severe OSAS with those specificities though, which are shown there. Then ODI3, you also come across it in literature. That is a more than 3% decrease in the saturation of oxygen. Now, ODI3 is floated as an alternative to ODI4 because there's a feeling that if we say a 4% decrease in the oxygen saturation, then we miss some children who actually have OSAS. So why not reduce that 4% decrease to say 3% decrease in the saturation of oxygen? However, if we do that, obviously the sensitivity of the overnight oximetry will increase, but however, the specificity will go down, which is quite natural. Sleep endoscopy is used to identify anatomic sites of obstruction. It's normally done after adenotonsillectomy. It includes awake flexible laryngoscopy and drug-induced sleep endoscopy. Drug-induced sleep endoscopy is done in supine position during a sleep-like state. The upper airway, it measures upper airway dynamic mechanics and identifies the level of obstruction. The results correlate to in-laboratory polysomnography findings. These are the common findings on drug-induced sleep endoscopy. You get, it's done post-adenotonsillectomy, as I've said. You'll find that obstruction could be caused by the tongue base or adenoid regrowth and or inferior turbinate hypertrophy. And it helps direct surgical interventions. For example, if you find a patient has got inferior turbinate hypertrophy, you would offer them a turbinoplasty, or if it's got adenoid regrowth, you can do a revision adenoidectomy. A drug-induced sleep sign MRI, it assesses the level of obstruction like the DISE which I just described. It's method to from resistant adenotonsillectomy, any child complete airway. Echocardiography or ECG, this is not routinely done. It can be done in suspected cardiac dysfunction or pulmonary hypertension and in complex disorders. So, why do we treat a child who snores? This is because they suffer a lot of complications, which include decreased quality of life, cardiovascular complications, central nervous system complications, nocturnal enuresis, and somatic growth delay. I'll go through these one by one. In terms of cardiovascular disease, they have activation of the sympathetic nervous system, increased oxidative stress, systemic inflammation, endothelial dysfunction, reduced nocturnal baroreflex again, which controls the blood pressure, abnormalities in cardiac structure and function. In terms of sympathetic system activation, this is caused by sleep arousals and hypoxemia. It results in increased peripheral vascular resistance and intermittent elevated blood pressure, and also heart rate variability. This can be seen in the raised urinary excretion of catecholamines. They tend to get cardiac failure because the baroreflexor system sensitivity is blunted, and also there's exaggerated negative intrathoracic pressure swings. All this causes increased systemic venous return, increased preload to increase. And if you do that, also in the cardiovascular system, they get endothelial dysfunction. They get increased levels of lipoprotein-associated phospholipase A2 plasma activity levels, which is an independent risk factor for atheromatous plaques. It is elevated in OSAS and obesity, and also it's elevated in endothelial dysfunction. The levels tend to decrease with OSAS treatment. However, the significance to cardiovascular risk is undefined. They tend to get oxidative stress because apnea and apopnea leads to oxygen tension changes. This promotes oxidative stress with elevated reactive oxygen species. So your oxygen radicals and radicals, they increase. And once they increase, they damage cells and biomolecules and alters their biological functions. And lipids are the most prone to this oxidation, and they are used as a surrogate. Confirmed in the plasma by elevated lipid peroxidation of oxidized low-density lipoprotein. There is a concern that OSAS also causes nocturnal enuresis. This has long been known that sleep-disordered breathing children tend to have enuresis, and this has been attributed to raised plasma BNP in OSAS. There is a resolution after adenotonsillectomy. However, there are no randomized controlled trials to confirm this. And there is concern that it might not actually be OSAS, because obviously once you do OSAS, these children, whether you do adenotonsillectomy or not, they will continue to grow. And it is known that nocturnal enuresis tends to decrease as the children grow older. So it could well be that, well, they just stopped having nocturnal enuresis, not just because of the adenotonsillectomy. But then we can't find that out because there's no randomized controlled trials. But it is out there in literature. They tend to get somatic growth delay and growth failure, though growth failure has been reported in preschool children with sleep disordered breathing. However, there's a paradoxical increase in weight post-adenotonsillectomy. This is known. And it has been found that overweight children tend to progress to obesity post-adenotonsillectomy, which then leads again to obstructive sleep apnea syndrome. In terms of the central nervous system, morbidity, they tend to get excessive daytime sleepiness, inattention and hyperactivity, cognitive defects, and behavioral effects. In terms of excessive daytime sleepiness, this is confirmed using the high modified Epworth sleepiness scale score and the pediatric sleep questionnaire. It tends to affect obese children more than non-obese children. Attention deficit and hyperactivity symptoms, it has been found that there is a relationship again between OSAS and ADHD, and this is based on subjective and objective measures of a sleep study criteria. Children with OSAS tend to get cognitive defects, and these are manifested in attention, lack of attention, executive functioning, poor language and memory, visual spatial planning and analysis, and processing speed. And in terms of behavioral problems, in the Tukasa study, sleep disordered breathing children were observed over 5 years and were compared to controls. Those with sleep disordered breathing were found to be more aggressive, tended to have lower social competency, poorer communication, diminished adaptive skills, and attention. Children to a child in item OSA quality of life vest, and this cause of post-adenotonsillectomy. So what should we offer the active sleep apnea? When do we have to treat a snoring child? We treat them based on polysomnography results if you have one available. You also treat them based on the presence of sleep disordered breathing associated morbidity, which I've just mentioned. And you also have to look at factors predicting the persistence of OSAS, and you treat them if the apnea-apnea index is 5. And then for apnea-apnea index of between 1 to 5 episodes per hour, you have to look for the presence of associated morbidity, and that will guide your treatment. If there is, that means we really have to offer them treatment. Also, if the McGill score 1, which we've talked about, the overnight oximetry score, if it's more than 1, that is more than a 90% positive predictive value for apnea-apnea index of more than 5 episodes per hour. Remember, the polysomnography is considered the gold standard. So whatever you do, it will be compared against the polysomnography results. So a McGill score of more than 1 has got a more than 90% positive predictive value for apnea-apnea index of more than 5 episodes per hour. So these children will need treatment. So the treatment includes diet and exercise, watchful waiting, and medical treatment, positive airway pressure therapy, and surgical treatment. I'll go through this. So weight loss tends to benefit obese patients. This includes diet and exercise and pharmacological agents which have been approved by some people have even gone on and done a bariatric surgery, a lot of literature on that. However, this has been found results on OSAS because the major challenge is the maintenance of the weight loss, because you can go ahead and lose weight, the child can go ahead and lose weight, but then maintaining that weight loss seems to be the biggest challenge. Montelukast and intranasal steroids can be used in single or in combination. They target cysternal leukotriene receptor 1 and glucocorticoid receptor alpha, which is abundant in tonsils and adenoids of OSAS children. In one study, it was found that Montelukast for 16 weeks reduced apnea-apnea index scores. And this was a randomized controlled trial of children who were aged between 2 and 10. Adenotonsillectomy, this is the first line. This is the workhorse of OSAS children. And it will be incomplete. They recruited 464 children aged between 5 and 9 years. And after 1 month, they randomized them into these two groups. After 7 months, they noticed that those children who had early adenotonsillectomy had reduced, improved secondary outcomes of behavior, quality of life, and polysomnographic findings, versus those who were put on watchful waiting. Those who were put on watchful waiting, 46% had normalization of the. But then the ENTs treating these children considered that 71% of them still needed adenotonsillectomy. However, in the two groups, there was no difference in terms of attention and executive function. So one of the things one has to consider in this study is that these children are only assessed after 7 months. So it will be interesting to see what would have happened to them after, for example, 3 years or 4 years in terms of the other morbidities of OSAS. And also that this study didn't include, obviously for ethical reasons, it didn't include those children with very severe OSAS who would have needed adenotonsillectomy anyway. So one has to bear in mind when you read this study. So post-adenotonsillectomy, it is known that there's a risk of upper airway obstruction and neurological injury on the first, especially on the first night post-adenotonsillectomy. And it happens in those children with severe OSAS and those with obesity and those with heightened analgesic and respiratory sensitivity to opioids. So the recommendation is that these children, after you do an adenotonsillectomy, you have to admit them overnight and do respiratory monitoring. And if at all you decide to give opioids, which we don't do at our institute at Red Cross, then you have to consider reducing the dose by at least 50%. Continuous positive airway pressure has been offered for residual obstructive sleep apnea syndrome after adenotonsillectomy since 1986. It effectively reduces the apnea-apopnea index and treats some of the morbidities associated with the OSAS in obese children, like hypertension and hyperlipidemia. However, it is known that CPAP helps in adults. It's actually one of the first-line treatments that is used for obstructive sleep apnea in adults. However, in children, there is concern about adherence and the suboptimal mask fit, nasal congestion or rhinorrhea, eye irritation, skin ulceration and discoloration, and risk of altered facial growth. So, does adenotonsillectomy actually work for complex disorders? For example, cerebral palsy. We know cerebral palsy, OSAS, is because of upper airway hypotonia, among the other factors that. So in these children, you would offer them adenotonsillectomy and you might consider giving them CPAP treatment. It has been found that there's improved OSAS symptoms versus controls, especially in parameters like sleep disturbance, daytime functioning, and reduced caregiver concern. Down syndrome is quite common here. It's of upper airway obstruction, and there's high prevalence of OSAS even without symptoms. They tend to have a low IQ, which is about 9 points lower than normal. They have generalized muscular hypotonia and pulmonary. So it is quite important to diagnose and treat OSAS timely in these children. So the treatment consists of adenotonsillectomy, and because they tend to have residual OSAS, a CPAP is also added to the treatment, and you can also add bilevel non-invasive ventilation, though adherence is a problem. In have nocturnal hypoventilation due to respiratory muscle weakness, and they've increased OSAS hypotonia, bulbar palsy, macroglossia, decreased lung volumes. So treatment for these will be adenotonsillectomy, CPAP, and non-invasive positive pressure ventilation. Achondroplasia, like the one I just showed, the polysomnography that we did, tend to have a high OSAS prevalence, and they have central apneas and hypoventilation, and they may show no improvement post-adenotonsillectomy. So in addition to adenotonsillectomy, you are giving them CPAP and non-positive pressure ventilation. Thank you very much for your attention. I will give the floor back to Tasia.
Great. Thank you very much, Dr. Mlauzi. That was fantastic. That was very, very informative. And it's quite clear to see that you have a passion for this kind of work. Thank you very much, and take care.
Thank you.